a quick introduction of Dr. Kozlov. She received her PhD in psychology from Washington State University in St. Louis in clinical psychology and aging and developmental psychology. She is one of our Institute core faculty members and an instructor in the Rutgers School of Public Health. Dr. Kozlov, take it away.
Thank you for the introduction. And I'll try to get us back on track with timing, so I'll zoom a little bit. I think, there we go. So I am going to talk a little bit today about an example of a practice-based research project, a much smaller scale example. And this is an mHealth mindfulness study for caregivers of older adults with MCI, mild cognitive impairment, or dementia. Next slide. This work was supported by a KL2 grant from the NJPBRN group, which is the Rutgers CTSA. Next slide. So there's two types of practice-based research. There's the type that transforms practice through changes in workflow or operations, which we've been hearing a lot about. And then there's a type 2, which is a recruitment-based within the practices. So this is going to be an example of a type 2 project-based research or practice-based research project. And I want to show this type of research, how it can be beneficial for both researchers and practices. And hopefully it'll be illustrative of the potential assets researchers can offer to practices. Next slide. So the background for why I conducted this particular study and why I did it in practice-based settings is that we know that informal caregiving has profound negative effects on the caregiver, as well as on, patients have a lot of difficulty as well, but the caregivers are who we're focusing on in this project. And we know that their mental health can really suffer. And for caregivers of dementia, of patients with dementia, these psychological stressors can be even worse. And typically we don't see a lot of management of the caregivers in primary care. And there's a lot of reasons for this, both systemic and structural. The caregivers are not the patients in primary care, and it can be really challenging to know what resources are available to help with caregivers as well. That being said, we know that caregivers accompany older adults to their primary care visits and are often in the room, and there's a real opportunity for an intervention point in the primary care network. Next slide. Oh, one back. There you go. Thank you. Mindfulness therapy is an efficacious psychosocial non-pharmacological treatment to help manage stress and depression. Typically, mindfulness treatment or mindfulness therapy is conducted with over 8 hours of face-to-face treatment with trained providers. And that's just not really a realistic option for caregivers, because we know that caregivers have tremendous competing demands for their time. The act of caregiving is incredibly time consuming. It can feel really challenging to add in weekly sessions with a therapist. And even if they were interested in weekly sessions with a therapist, there's a real mental health provider shortage in our country, as well as issues on adequate reimbursement for providers. And so the thinking here is that mHealth strategies might be a really useful way to overcome some of these traditional barriers to people having access to psychotherapy. Next slide. So the purpose of this particular study was it's a small scale pilot study, but we wanted to determine the feasibility, acceptability, and preliminary efficacy of mindfulness coach, which is an mHealth mindfulness therapy. And we wanted to see how this worked with caregivers of patients with dementia or cognitive impairment in the primary care setting. Next slide. And so we were primarily looking to evaluate the feasibility, acceptability, and preliminary efficacy to alleviate stress, pain, anxiety, and depression for caregivers of older adults with dementia or cognitive impairment. Next slide. And we were hopeful that it would be all of those things: efficacious, feasible, and acceptable. That was our preliminary hypothesis. We can go to the next slide. So let me tell you a little bit about the mobile app. It's called Mindfulness Coach. You can all actually download it for free in the iOS or Android App Store right now. It's got a little green leaf as the icon. Mindfulness Coach was developed and designed by the Veterans Affairs National Center for PTSD Research. It is not a PTSD specific app. However, it was designed based off of the VA's mindfulness training course. And it's designed to be engaging and to be a good overview and introduction to mindfulness therapy, regardless of specific psychiatric illness or diagnosis or patient population. So it was not designed for older adults. It was not designed for caregivers of patients with dementia or cognitive impairment in particular. So in order to add some specificity to the intervention, we developed an orientation that focused on coping with caregiver distress, as well as instructions on how to use the app. And we also included the occasional phone check-in to promote engagement. This was all done by a research assistant who was trained in how to conduct the orientation. Sorry, just go back one sec. I just want to show you the interface of the app is really simple. There's 4 main areas. If you do the mindfulness training button in the top left, it takes you through a 14-session training program that includes psychoeducation, mindfulness exercises, as well as seated practices. And these sessions last from about 5 to 20 minutes. So the idea is for this to be fairly accessible and low burden for people to use. Okay, next slide. So the initial study design was to recruit 60 caregivers from the RWJ Barnabas geriatric primary care clinics. We targeted 3 sites in particular to work with. And our plan was to begin recruitment in November of 2019. But as you can imagine, starting our study in November 2019 and then planning to go for the next 1.5 years, we encountered some interesting challenges due to the COVID-19 pandemic, which we'll get into in a little bit. But the initial plan was to conduct research in the clinics from November 2019 until we completed our recruitment. And we would follow up with our participants at 2 weeks, 4 weeks, and 8 weeks via telephone. So there was only going to be 1 in-person session to show people how to use the app, help them download it, give them the orientation, and then everything else is going to be phone-based in order to reduce the burden on the participants. We use this app as well because the VA has a research-based version that you can use for free, which collects additional passive data, things like how many times did people use the app, how long did they spend in the app, which areas within the app were they using the most. So all of that was simultaneously and seamlessly collected passively. Okay, next slide. So we had a lot of different recruitment strategies back in November of 2019, which feels like a completely different era at this point. But initially we were meeting with and we were having meet and greets with the practice staff to tell the providers and support staff at the clinics about the program of research and really try to establish rapport and a relationship to help ensure that the providers viewed our research as an asset to their clinic. And I can't really emphasize this enough. You know, I really wanted to make sure that practices saw my program of research as a potential resource for their patients. You know, we were going to teach them how to use a meditation app. We were going to follow them. The caregivers got paid a little bit. And in the absence of, an extremely robust mental health system integrated into a primary care clinic, which is rare, but available in some places, we were hoping that we could sort of fill in some of the gaps to help provide caregivers with some additional resources. And we met with the practices on several occasions to talk through how we could more seamlessly fit into their existing infrastructure. And I was trying very hard to acknowledge that, I appreciate that clinicians are not paid for referring folks to studies. Their infrastructure is such that they're seeing patients all day. It's busy, it's stressful. And I really did not want to be viewed as a burden or any way interfering with the workflow that is already so rigorous in these primary care groups. We discussed different options that would make the research feel more seamlessly integrated into the existing infrastructure. So one practice said, send me Monday morning reminder emails. If I don't get a reminder on Monday morning, I'm not going to remember to do it throughout the week. So I would send Monday morning reminder emails to certain providers who requested it. We leveraged pre-existing referral sources. So some of the practices had caregiver support groups, which were very open to me coming and pitching the study to the existing caregiver support networks. But what ended up being the most effective until the pandemic hit was that we had a research assistant camp out in the lobby of one of the practices when we knew that there would be a heavy patient flow day to try to facilitate the warm handoff and kind of remind practices about our study in real time. So that was the initial plan. Let's go ahead and next slide. But then the pandemic hit and we couldn't go in person anymore, and the workflow completely shifted and practices were scrambling with staffing shortages and converting to telehealth. And as you can, and my IRB had to change because we could no longer meet in person with participants. And so as you might imagine, the best laid plans went awry and we had to pivot, which is fine. We were happy to do that. And I think probably the end result of this study is that it ended up not being entirely a practice-based research program, because during the pandemic, it was just a tremendous challenge to figure out how to continue a fruitful research relationship when we hadn't been there very long pre-pandemic, and everyone was just trying to do the best they could with the resources they had available. So next slide. We ended up shifting to a variety of referral sources, including the practices. So here's the kind of variables that we were collecting throughout the study. We were looking at depression, anxiety, pain, caregiver burden, quality of life, stress. And then did the caregivers like the app? Did they find it useful? How much time were they spending in the app? Things like that. Next slide. Here's a breakdown of our final sample. So we ended up recruiting 62 people dropped out in the middle, or rather we couldn't continue to follow them. We lost them to follow up. So we had a total of 58 completers, and unsurprisingly, primarily female, primarily caregiving for a partner, and really doing a lot of caregiving hours per week. The sample was a little bit older, skewed older, with a mean of 61 years of age. And about 2/3 of them lived with their patient for whom they were providing care. Okay, next slide. Thank you. The good news is that the caregivers really liked the app. They found it really useful. They would recommend it to a friend. They were satisfied with it. They thought that using it was easy and that it gave them new skills and new information. So the overwhelming majority of our sample really found the app acceptable and useful. Next slide. And they were using it a lot, which I think is a really important finding. This idea that health strategies may or may not be acceptable to older adults in particular, or to caregivers who have a lot of competing demands, is we're starting to challenge that, because the more research we're doing, the more we're finding that people actually really like these strategies. We've started to do some qualitative interviews as well with the participants, and we're finding that people are reporting that having the ability to do a quick 20-minute meditation is actually way more useful for folks than trying to schedule an hour-long therapy session each week. So it's been really nice to hear why this app is particularly helpful and useful for the caregivers, and it's a really promising avenue for future research. Next slide. And this is all just pilot data, but we showed that the psychological symptoms are decreasing over time for the caregivers, which I was going to be pretty comfortable with stayed the same, because we know that caregiving can become increasingly burdensome as dementia or cognitive impairment progresses. So I was comfortable with a pilot data of seeing things stay fairly static, but we actually saw reductions in depressions, reductions in anxiety, reductions in burden. There was a COVID-19 effect. So, we started recruitment pre-pandemic and finished recruitment in December of 2020. So we wanted to model the difference between how people interacted with the app and how efficacious the app was based off of when in history they were using the app.
Hey, how are you? So on my plate for today
Can someone mute themselves, please? Thank you. So this is the preliminary efficacy of the effects of study weeks on psychological outcomes. So we're seeing over time, people's symptoms are reducing. Next slide. We also saw that the more hours they spent using the app, the greater the reduction in psychological symptoms for the most part. We do see a little bit of a quadratic effect, which we can talk about in a different venue, but in general, we're seeing significant reductions. So as people use the app more, their symptoms are remitting more. Next slide. So the takeaways here are that this was a well-received pilot study. The caregivers liked it. They reported decreases in psychological distress, and recruitment for any caregiver research program is a challenge. You talk to any caregiver researcher and they'll say the number one challenge is finding the caregivers, but partnering with the clinics pre-pandemic was an incredible asset to me as a researcher. And hopefully from the study's results, you'll see, if you're on the practice side, that it's an asset for the patients as well and for the caregivers as well, because this is just one example of an intervention study that seems to be promising, at least in terms of being an acceptable, feasible, and efficacious and free, let me emphasize, free intervention to offer your patients and their caregivers. Next slide. So hopefully for researchers, we know that finding patients is hard, and partnering with the practices can be a big help. For practices, this is an opportunity for you to get early access to innovative interventions and other opportunities for your patients. And often it's a way to expand services to your patients for no cost. And sometimes we can even offer financial incentives for both the patients and sometimes practices too. So hopefully this was a helpful example to see, when we talk about practice-based research networks, this is also a version of what the collaboration can look like between researchers and practices. Thank you.
Thank you, Elissa. I was really excited to have you present this project because it highlights such an innovative tool that's introduced into a practice setting that maybe they wouldn't have known about. And you emphasize that it's free. And furthermore, you're providing some real-time data back to the practices about whether or not these tools are working for their patient populations. And that's something that's really important about what we're trying to do more broadly with our network and helping researchers and practices connect to, at the end of the day, improve their population health management. If there are any questions for Elissa, please put them in the chat or raise your hand. Or in the interest of time, we also can move it on to our next session. I know that Steve had his hand raised, but I think that might have been for the previous session on NJI's work. Oh, I see a question from Dr. Weber. Go ahead and please unmute yourself.
Thank you, Anne, and also Elissa. Not only fascinating research, but I had earlier put in the chat a point about the quadruple aim, and once again, this is really a fantastic, and very important research and effort that you're doing that already is demonstrating increase in vitality and resilience, which again is the spirit of the quadruple aim in comparison to the triple aim, which is so nicely presented earlier. So I congratulate you on the research, and certainly I look forward to seeing more as it comes along. I'll just add to you that, with my another major responsibility I have regarding teaching our health profession students, primarily the med students, we put a lot of attention to vitality and resilience. So, and in fact, and specifically, speak about mindfulness and have them select apps and so on. So I would, love to get there. You may even want to reach out just to get some informal feedback, or even formal feedback from them, because they are very, very attuned to using mindfulness apps and wellness apps. Thank you again. and good luck.
Thank you. Well, hopefully the next round of this is going to be dyadic. So giving the app to both patients and caregivers to see if we can enhance each other's coping skills together. I see a question in the chat box, so let me just get to that. Do you feel that caregivers were hungry for this kind of information? You know, that's a great question. I think what's hard with caregivers is that some of them are, and some of them are so overwhelmed that the idea of doing one more thing, even if that one more thing is self-care or taking, you know, steps towards their own mental health, can be a real challenge. So I think there's a lot of individual variability on that front. But, you know, the nice part was that when participants did engage with our research program, they were overwhelmingly positive and we're really grateful for the opportunity. So sometimes hard to get them in the door, but once they were in the door, they were really grateful for the additional resource. And this was another place where having the physicians as our referrers and allies was an incredible resource. So I had a couple of physicians who got really involved in the project. And when the referral to do this kind of research program comes from your loved one's doctor, it's kind of a different recommendation than grabbing a flyer from the waiting room. So thank you for that question.
Yeah, great note to end on. And so with that, thank you, Elissa, for your wonderful presentation. And